Hello, my name is Katie Courtney, and this is my presentation on Alzheimer's disease based off of the case study found on page 177. The patient's chief complaint is, quote, "I got lost in the grocery store and my children think that I need those diapers that old people have to wear." Quote. History of present illness and symptoms. The patient, RM, is an 83-year-old woman who presents to the geriatric care clinic for a routine visit with her two oldest daughters. The patient was diagnosed with Alzheimer's disease 9 years ago when she first started to have short-term memory loss and several cognitive manifestations. Her daughters report that she was constantly misplacing her glasses, hearing aid, keys, and had placed items around the house in places they did not belong. The example that was given is that the coffee pot was found to be in the fridge. The patient also got lost while taking a walk in the neighborhood she lived in for 45 years and had to be helped home by neighbors multiple times. There have been changes in her behavior, and her personality has changed. She was once a vibrant, outgoing person and has now become quiet and passive and has seemed to lost motivation and enjoyment in the activities she loved. Her workups have been negative, but there has been a lower scoring mini mental state exam. Her initial score was 25 out of 30. But then, her last score before today's appointment was an 18 out of 30, slowing a slow progressive decline. There also happened to be more changes noticed 4 years ago, as there were atrophic CT results. These results showed that the CT scan revealed moderate to severe cerebral atrophy in the temporal and parietal lobes bilaterally. In the past 6 weeks, a greater behavior change has occurred, and within 2 weeks ago, occasional urinary accidents started happening. This patient should be tested for a UTI, as that could be the cause. However, it could be a sign of the dementia and Alzheimer's disease worsening, as that can be one of the clinical manifestations. The patient's family is now becoming concerned as they feel that they might be unable to manage their mother and are considering a long-term nursing care facility. RM's medical and surgical history. The patient has had hypertension for 20 years, had an episode of nephrolithiasis 2 years ago, and the stone was able to pass without intervention, and there was a uric acid primary component to the stone. The patient was also diagnosed with gout 2 years ago. She had hypercholesterolemia for 6 months, plantar fasciitis of the left foot for 3 months, and occasional constipation. There was no surgical history mentioned in the case study. This would be a question I would follow up with in the office. The patient's family history. The patient is 83 years old and both parents are deceased. The father died from a CVA. The mother developed Alzheimer's disease in her 70s. It is unknown at which age she has passed. Her brother died from heart disease. And her sister also had Alzheimer's disease and died 5 years ago at the age of 76. Notice that both the patient's mother and sister had Alzheimer's disease, and her father and brother had vascular issues. The patient's social history. The patient lives with one of her daughters. She has been widowed for 14 years after her husband died from cancer, and she states that she does not smoke or drink alcohol. I would ask RM if this is something new or if she had never smoked or drank alcohol. In this slide, you will see the patient's data obtained from the office visit today. Their blood pressure was 140/80 as they were sitting, pulse of 85 and regular, respiratory rate 15 unlabored, temperature was 98.8 in Fahrenheit. The patient's height is 5'6", and the patient's weight is 114 pounds. There's also some diagnostic tests on the right side. I stated that the mini state exam is 9 out of 30, which is a significant decrease from the 18 out of 30 from their last visit. And I also stated that I have a urinalysis pending. In the office, I would test the patient for a UTI due to the urinary accidents only starting 2 weeks ago. This could be related to a UTI, which could add to the patient's confusion and decreased mental state. However, urinary accidents are seen in the later and more severe stages of Alzheimer's disease and dementia, so it could be a sign of the disease progressing further. These are the blood test results from a fasting study. As you can see, none of the lab tests are extremely out of range. The magnesium was noted to be just above range, but there is no white blood cell count. The magnesium is within normal range, chloride. The uric acid is in range, which is good because the patient has had gout for 2 years. Her cholesterol, which she has had a history of hypercholesterolemia for 6 months, is also in range. So these signs are a good indicator that there is not a different underlying cause to the patient's continually progressive memory and cognitive impairment. The next 2 slides contain RM's physical exam findings. In red, you will notice the findings that were abnormal. In general, the patient seemed slightly confused, but was a cooperative elderly woman and did not appear in distress. She became less confused with slowly repeated questions and simple explanations. The patient was noted to have a significant tick of the upper lip, about 2 to 3 twitches a minute. Her skin was pale and dry with senile lentigines. It had poor turgor, and there were multiple minor ecchymosis noted on the forearms with no other lesions or abrasions. The patient's funni was in with normal limits. All membranes were intact. The patient had their dentures in, and their membranes were moist without lesions. Their neck was supple, their trachea was midline, and the patient's carotid pulses were full and equal bilaterally without bruits. Within the chest and lungs, there were a mildly increased chest anterior-posterior diameter, and the lungs were clear with auscultation. The heart had a regular rate and rhythm. It was a normal S1 and S2, and there was no murmurs or rubs heard. RM physical exam findings continued. The abdomen was soft and non-tender. They were symmetric with no apparent masses or hernias, no scars or lesions present. However, all bowel sounds were present, which is a good sign because the patient reports intermittent constipation. There is tympany to percussion in all quadrants, and then no masses or organomegaly was noted. While examining the patient's neural functions, The patient's gait was slightly wide-based and awkward, and the patient was unable to tandem walk. There was no Romberg sign. Her D10 and reflexes were 2+, a negative Babinski, and the other abnormal finding was that the patient was able to feel a key in both hands with their eyes closed, but unable to identify this common object. This is called a stereognosis, and it is a marker of cognitive impairment and dementia due to the post-central and parietal lesions. In the breast, there were no masses or tenderness or discoloration, discharge or dimpling. It was normal external genitalia, and the musculoskeletal and extremities did not have any redness or swelling noted to them. They were both warm, and peripheral pulses were intact, all except with the exception of the left great toe, which was tender with movement. The joints show a smooth range of motion and no crepitus or tenderness. What are the genetic factors for Alzheimer's disease? There is a strong familial inheritance risk factor. However, that does not mean that if your siblings or family members have Alzheimer's, that everybody will develop it. What has been noted is there are risk genes and deterministic genes. The risk genes mean that the likelihood of developing the disease is increased, but it doesn't necessarily guarantee that it will happen. However, there is a specific gene that they have determined as a deterministic gene that is rare, and it is only in 1% or less of families that have Alzheimer's disease. And if this disease is present, then you will have Alzheimer's. The difficulty with that is noting when Alzheimer's will be diagnosed, and it normally occurs with a person's early 40s to mid 50s. Are there other risk factors to Alzheimer's disease? Yes. The risk factors included are age, head injury, vascular disease, Down syndrome, and race. Vascular disease or even hypertension is a strong risk factor, and the patient has had hypertension for 20 years. In race, Latinos are about 1.5 times as likely as older white people to have Alzheimer's and other dementias, while older African Americans are about twice as likely to have the disease as older Caucasians. The reason for this differences is not well understood, but researchers believe that higher rates of vascular disease in these groups may also put them at greater risk for developing Alzheimer's. This is an important reason, too, of head injuries and in sports when younger to make sure we're using proper headgear. This is a list of the patient's current medications. It is convenient to have medications written down to be able to provide to your doctor to ensure an accurate listing. Next to the medication is also the reason why the patient would be prescribed this medication. It goes through their dementia related to Alzheimer's, the patient's gout history, their high cholesterol, the hypertension, nutrition, pain relief, and even the medication prescribed for the patient's occasional constipation. RM has a listed allergy in the case study of cotrimoxazole. It states that the patient developed a rash. It would be important to know when the patient encountered this allergy and if they have gone through allergen testing. In the bottom right corner, you will find a picture of what a rash could be like with an allergic reaction. In this case study, RM did not have any stated cultural or spiritual background. this would be something that is important to make sure that you're following and that you're not infringing on their cultural backgrounds. And I would ask RM or the patient's daughters if there was any preferences the patient has. The definitions and information on this slide are by Dunphy 2023. What is Alzheimer's disease? It is a progressive neurodegenerative condition, and it is the most common form of dementia in the older population. It is known to be the cause of 60 to 80% of dementia cases in the older population. It has an insidious onset with a slow progression of cognitive decline. The cognitive impairments that occur are memory and learning deficits, and then also it can progress to language and aphasia, learn motor function, difficulty moving and doing tasks that somebody have normally done. And then, in most cases, there are also behavioral changes that occur, aggression and irritation, and can even become with depression. The disease Alzheimer's was named after Dr. Alois Alzheimer. In 1906, he had a patient who he noted brain tissue changes to. The patient had died of an unusual mental illness at that time. She had the symptoms of memory loss, language problems, and inappropriate behavior. Upon the autopsy, Dr. Alzheimer found that there were microscopic clumps of abnormal proteins in her brain. These proteins were amyloid plaques and neurofibrillary tangles. Due to these new findings, Dr. Alzheimer's named the disease because before then it had not been characterized. The epidemiology of Alzheimer's disease. The incidences of Alzheimer's in the general population increases rapidly with age. It affects approximately 1 in 10 people older than 65 years of age. It is also the 6th leading cause of death in the United States and the 5th leading cause of death among patients that are older than 65 years of age. It is estimated that 5.8 million Americans have dementia due to Alzheimer's. And this estimate is figured to grow to 18.8 million by 2050. The increase in people with dementia in the United States is going to be around 16%. The prevalence of dementia is higher in people of color than in whites, and this is unknown, as spoken about earlier, in risk factors, and could be related to patients that have a higher chance of vascular disease due to genetics. It is difficult to predict the survival time due to the different onset and how it can slowly progress. However, the life expectancy is approximately 7 to 10 years after diagnosis for individuals who are 60 to 70 years old. Although the general population is normally diagnosed at an older age, early onset affects 200,000 individuals that are younger than 65 years of age, and these younger individuals normally have that rare familial form of Alzheimer's disease. This inheritance is known to be a dominant trait, and if a parent of an offspring has Alzheimer's disease, that child has a 50% chance of developing the disease. I will explain the pathophysiology of Alzheimer's disease in the next 3 slides, the last slide including a picture detailing the progression of dementia. Alzheimer's disease works by depleting the cerebral cortex and causes atrophy. It's causing this atrophy on the neurons. Neurons using the acetylcholine neurotransmitter are the ones that are most susceptible and are known to be the ones that are most degraded. The cortical areas that end up most affected are the hippocampus, the amygdala, the temporal cortex, the olfactory system, and intercortical connections. The olfactory system being affected is why patients have that altered sense of smell and taste. There are also pathological changes that can be seen in the brain. As mentioned earlier, Dr. Alzheimer had found protein and plaques in a woman's brain. This is due to the neuritic plaques in the fibrillary tangles. The neuritic plaques are microscopic spherical lesions that are found throughout the cortex. This can happen due to the excess of the beta amyloid, which is a protein that ends up misfolding, and it is found throughout the cerebral cortex, the cerebellar cortex, the basal ganglia, and it is also noted to be found prominently around blood vessels. Pathophysiology Part 2. The neurofibrillary tangles are microscopic collections of intertwined cytoskeletal fibers that form inside of neurons. This creation causes a high density that directly correlates to a patient's dementia status. The more fibers and intertwines that are created and seen, the more severe the patient's dementia status is. Within these tangles is a protein called tau. This protein is the most abundant, and it is seen to have a direct correlation with Alzheimer's disease. This protein can be detected in a patient's cerebrospinal fluid, which is one of the tests I'll talk about later in determining if a patient has Alzheimer's disease. The tangles end up immobilizing and deactivating the cytoskeleton, leading to cell death. As you can see in the picture to the right, the left side is healthy and the right side shows this plaque buildup of Alzheimer's disease. Once the cell dies due to these tangles, it then becomes this entanglement that is just left and it's insoluble and it remains in the brain. Even when the neurons have been degenerated, this insoluble mass still stays in the brain. The function of this precursor to beta amyloid protein is still not yet fully known, but the byproduct of it broken down is one of the main theories that they're suspecting leads to Alzheimer's disease and is causing all of these clots in the brain that further progresses Alzheimer's. This picture shows the progression of Alzheimer's disease. It starts with the mild cognitive impairment and then goes through the mild Alzheimer's, then to moderate, and then severe. Under each step, it lists the duration and how long this could typically last. Goes over how mild cognitive impairment is the disease and it begins in the medial temporal lobe. It then progresses and spreads to the lateral and temporal and the parietal lobes. Then the disease spreads to the frontal lobe and the disease finally spreads to the occipital lobe. It also gives you a picture of what symptoms to expect while this disease is progressing. Initially, you'll start seeing the short-term memory loss, like forgetting where the keys are or where you misplace objects. And then it starts to develop further, and there's reading problems, poor object recognition, and poor sense of direction, like how RM kept getting lost in a neighborhood that she had lived in for over 45 years. Then it goes into the poor judgment, impulsivity, and short attention. This would probably be about 4 years ago when the patient started to have some more behavior changes that the daughters recognized and are concerned for. And then it starts to develop even further, which is the severe Alzheimer's, and this would include visual problems and more difficulty understanding. In this slide, I'll be going over the clinical manifestations of Alzheimer's disease. And while these are generic topics, Alzheimer's can look different for everybody. Some can start with slow memory progression, and others can end up developing Alzheimer's at a faster rate. The clinical manifestations are learning and memory impairment, like getting lost in a familiar place, difficulty completing tasks or coordination, which would end up developing into later stages of being unable to dress and bathe themselves, and as RM is developing, becoming incontinent. They'll have unable to reason, and this is due to their parietal lobes ending up with these plaques, so their mind is unable to process and to reason with these conversations they're having, and that is why it is better to speak simply and sometimes having to repeat yourself so the patient has time to process. This patient can also have expressive aphasia, and being in the spot where they're difficult to communicate their needs can add to their changes in behavior. When someone is unable to communicate what they need, it can make them become irritable or hostile, or sometimes they end up withdrawing themselves from situations, which then adds into depression. It can make them anxious. It also can cause changes in behavior by impulsive sexual behavior, delusions, and paranoia. This is not seen in this case study, but it is a common clinical manifestation of Alzheimer's disease. And these patients can also have difficulty with spatial relationships. The diagnostic criteria for Alzheimer's disease. Diagnosing Alzheimer's is a lot of ruling out other conditions that can impair brain function. So using laboratory tests like the blood work to rule out other differential diagnosis is what should be done first. Then a patient could undergo a structural MRI, and that can rule out alternate diagnosis as well, and it can also look for radiological biomarkers such as that cortical atrophy and the focal hippocampal atrophy. The next scan that could be done to help rule in Alzheimer's disease would be PET imaging. So this PET imaging could be used by using that amyloid protein tracers, and it could detect deposits which would be indicated of Alzheimer's disease. This test is 86% accurate in predicting development within 2 years, and it is 92% accurate in ruling out the likelihood of the development of Alzheimer's altogether. If there aren't these plaque developing of the amyloid protein, it is less likely that the patient will have Alzheimer's. The amyloid proteins are seen to be a big factor. As mentioned before, the amyloid protein and the tau become more prevalent in Alzheimer's disease. Checking for this prevalence will help rule out other causes. You can also use the mini mental state exam, which was done to the patient. This can help to show their progression and how their mental state possibly is declining, or even if it is the slow progression. You document the patient's same examples. Then the next thing I have listed is to follow the signs. This is because there is a set of signs that can indicate somebody is starting to develop Alzheimer's disease. These signs would be if there are and absent of any precipitating medical illness that could cause cognitive impairment, if there's an absence of drug-related phenomenon, so if the patient is not using drugs regularly and that is not affecting their cognitive impairment, and then the presence of objective, well-documented, progressive, and worsening deficits in new learning and memory. This is where the mini mental state exam would come in, as you can document the slow progression. And then also the last would be signs of functional impairment. They're having difficulty doing their ADLs, and they start to be able to depend on others and are unable to function independently. For the pharmacologic treatment plan, I split it up into the generic treatment plan for anybody with Alzheimer's disease, and on the right side, the specifics I would do for the RM case study. So cholesterol inhibitors can help to improve cognitive function and have been seen to be very effective in Alzheimer's disease per our textbook, Dumpy 2023. And Donzaville, the medication that the patient is already prescribed, is one of the most known and well preferred medications, and this is based off of UpToDate. The N-methyl-D-aspartate receptor antagonist also has additive effects when combined with a cholinesterase inhibitor in moderate to severe Alzheimer's disease. Antidepressants have been shown to be effective in patients who are suffering from depressive symptoms with Alzheimer's, and it is seen that pharmacological management needs to be started sooner for better outcomes in Alzheimer's disease. There is no cure for Alzheimer's, but it is seen with patients who start pharmacological measures sooner are known to slow down the progression of the disease, and it protects their physical health, emotional, and their optimal functioning. So in the case study, I would keep RM on donzapil, and that dose is 10 milligrams, which is the highest dose. A patient would start on 5 milligrams and then be increased. And there is no known clinical benefits to increasing the dosage any further. And that's based off of UpToDate as well. But I would also add in the N-methyl-D-aspartate receptor, and the most common one is memantine. And that is something that would be started at 5 milligrams daily, and that can be increased to 10 milligrams if the patient is tolerating it. And since the family is reporting some depressive symptoms, that the patient is withdrawn or not participating in activities, is more quiet than normal, I would also recommend starting the patient on an antidepressant to see if that can help bring out some of the patient's old behaviors and make the patient become more lively. For the lifestyle treatment plan, I found it to be the same as the generic and what I would recommend for this case study for the patient RM. It is important that the patient is still receiving good nutrition, as seen the patient is supplementing with ensured drinks. There are many other different kinds of protein drinks and supplements as well, which would be important to recommend to the patient and family members if the patient is seen to be eating less. Referring to a dietitian can also help to ensure the patient's maintaining proper nutrition. The patient should also be getting exercise. In more severe cases, OT or PT referrals could be made. There also should be preventative care. Even though a patient might be seen as declining, this care should still be having their immunizations, dental work, vision, and hearing aids or other ways to prevent hearing loss. Having these other issues can add to a patient's frustration and make them become more irritable. Having set routines for a patient can also help. It helps them get into it, and it can help with their cognitive function, so they have a set thing to do each day. And then making sure that the patient is spending quality time with family and friends. Although it might be frustrating, especially when the patient may not remember people, it's important to boost the emotional function of the patient by having them go out and do things with their loved ones. Patient education. Even though the patient does have a cognitive impairment, the plan should be talked through and gone over with the patient, and then again with a family, a friend, or support member. The patient should feel involved in their care, and we should make sure we're still making it patient-centered. We need to let the patient know that the Donzapil does not prevent the progression of Alzheimer's disease. However, it can slow the rate of decline. People think when they take a medication that it can stop everything, and we need to make sure that this is clear, that it is not a cure for Alzheimer's. We also need to ensure that the patient is taking care of their physical and mental health. As I said, making sure they're still spending time with friends and still going out. Even though RM is getting lost on walks, it may be important that a family member or a neighbor will take a walk with the patient instead of the patient being told they can't take walks anymore, as that might be their one form of exercise, or it might be limiting themselves from their emotional health too, and being able to get out of their house since driving privileges have been revoked. When speaking with the patient, it's important that you're simply talking and that you're speaking clearly with them. You might need to repeat yourselves, and it's important to explain to the patient that if they need further explanation, not to be afraid or embarrassed to ask, and that this is something normal that occurs with patients with Alzheimer's disease. That reassurance and acknowledging that the disease can be frustrating can also help a patient feel more at ease, especially if they're becoming more irritable. And we need to remind them of their support systems. It seems that this RM has the two oldest daughters at the appointment with her, and making sure that they know that the family is there to help them and that they are not trying to take them away from their home, and that they are just supporting them in the best way that they can, and letting them know that it can be frustrating for the family members as well, and that they both need to work together as a cohesive team. In the last slide with patient education, I talked a little bit about the family education and how it is important to remember that the patient is going to be frustrated just as they are. But it is important that the caregivers know it's important that they need to care for themselves. As nurses, we know that we need to make sure we're caring for ourselves to be able to properly care for others. And sometimes family members don't feel that way, and it can be very bothersome to them, and they can blame themselves when they're unable to manage the care for their loved one. They also need to be aware that the medication will not cure the disease, but it can help slow the progression. They need to support each other, to be kind and patient with the patient or their family member, and to start conversations by orienting the patient to who you are. So it might be helpful if they have a friend come over to visit saying, hi, my name is Bob and we used to work together. It'll help jog the patient's memory. And even if it doesn't, a reminder to whoever's coming over to not get frustrated with the patient, because that patient will end up getting frustrated and it can take an emotional toll on them as well. Photo albums are a great way to pass time for a patient, as their older memories are known to stay longer and their short-term memory is what to go first. My follow-up and referral recommendations would be if that UTI test is positive, to treat it. However, if it's not, then we need to move on and to start focusing that the dementia and Alzheimer's is progressing. I'd also do a referral to a memory disorder center if there's not one already. And then since the family is considering long-term care facilities, I would refer them to social services. And then I would want to check in with the patient in 1 week to see if they're tolerated that new medication, mermantine, and if they are, then I could increase the dosing. Community resources and supports can be very helpful for the patient and their family members. Social work not only has to be a referral, but could also be community involvement. Instead of possibly doing long-term care, I would advise them maybe considering a home care aide to come in. That way they could still be in their house, but they would have somebody there helping them that has gone through this, and that can hopefully help to decrease frustration. There's also programs for meals to help with nutrition that family members can make. I'd also recommend a support system, not only for the patient, but for their family and friends. A support group that they can go to and talk to other people who have loved ones that are going through Alzheimer's disease. And then there's also an Alzheimer's hotline number that people can call 24/7 to get advice and helps and tips. My genius questions for you are: 1. What could be the cause of the patient's tics? 2. What is the difference between Alzheimer's disease and dementia? And 3. Is there a known relationship between cerebral vascular accidents and Alzheimer's disease? I look forward to seeing your answers. Here is a list of the references that I used to obtain information for this case presentation. I chose this topic because it is personal to me. My mother was recently diagnosed with Alzheimer's disease, so going through this, I was finding out a lot of what I can expect, and it was interesting the more information that I went through. So I hope you guys enjoy it.